Person and all esteemed colleagues, over next 18 to 20 minutes I am going to take up the topic of subtypes of type 2 diabetes, a tale of two worlds. Type 2 diabetes, I am going to start my presentation with a question. Is type 2 diabetes a single entity or several subtypes? So type 2 diabetes is caused by a combination of genetic and environmental factors. About 10% of patients diagnosed to have type 2 diabetes could actually have LADA, that is latent autoimmune diabetes of adults. Another 1 to 5% may have autosomal dominant inherited forms of maturity onset diabetes, which is MODY, and 1% may be harboring rare genetic mutations. However, the majority, 85 to 90%, have the garden variety of type 2 diabetes. And diabetes, as we all know, is a heterogeneous disease associated with a large variation among patients in types of complications and rates of disease progression. The rather simple classification into type 1 and type 2 diabetes does not reflect this. Hence, a sub-classification of individuals with type 2 diabetes into distinct clusters could help in identifying and deciding management of individuals at high risk for developing complications. In 2018, Ahlquist and colleagues proposed a new classification of diabetes consisting of 5 clusters of patients with different risks of complications of diabetes and differing underlying disease mechanisms. So what are the advantages of clustering of type 2 diabetes? Basically, if we are able to successfully cluster our patients of type 2 diabetes, we can accurately classify them into different subtypes, plan their therapies based on pathophysiology, predict prognosis and prevent diabetic complications, and probably the whole process or the exercise helps us in offering precision medicine to our patients with type 2 diabetes. I am going to initially look at the tale of the Western world, and basically 3 distinct models of heterogeneity have been proposed while classifying diabetes, and we'll go through each one of them. The type A is the traditional classification of diabetes, where type 1 and type 2 diabetes are viewed as distinct subgroups, but there is a component of overlap, and that is probably the LADA variety. Type B is the palette model, where many molecular pathways involved in a diabetes pathogenesis are represented as colors, and each individual with type 2 diabetes is represented by mixed colors of all the pathways affecting that particular individual. And the NDIS, which is the Swedish model, where colors instead represent clinical parameters, and they reflect the underlying mechanisms, and that are really easy to capture in our day-to-day practice also. So this is the 5 clusters are magnified here, subtypes of type 2 diabetes. So basically, individuals were subgrouped using a data-driven approach based on 6 commonly measured variables known to reflect central disease mechanisms. They are age, BMI, HbA1c, GAD antibodies, GAD antibodies, and homeostatic model assessment of the beta cell function of insulin resistance. These were the 6 parameters used, and the clustering resulted in 5 subtypes. First is severe autoimmune diabetes, that is SAID, severe insulin deficient diabetes, that is SID, and mild obesity associated diabetes, that is MOD. You have severe insulin resistant diabetes, that is SIRD, and then mild age related diabetes, that is MARD. And such sub-classifications are going to help in our day-to-day practice in offering very precise treatment and in picking up or predicting complications in our patients. And at the same time, the clusters do help in research work, may it be genetic based, or looking at further mechanisms of the disease, or planning appropriate clinical trials. So 6% of the NDIS cohort, around 8,980 patients, were GAD antibody positive, and they were classed under the cluster SAID, severe autoimmune diabetes, with GAD positivity, low insulin secretion, poor metabolic control, and remaining 4 clusters had GAD antibody negativity, and they were classified on the basis of HbA1c, HOMA-B, HOMA-IR, BMI, and age. So 18% conformed to severe insulin deficient diabetes, where there was low insulin secretion, poor metabolic control, increased risk of retinopathy and neuropathy. 15% belong to severe insulin resistant diabetes variety. They had insulin resistance, obesity, late onset, and typically late to start the story of diabetes, increased risk of nephropathy and NAFLD, that is fatty liver. 22% fell under the mild obesity related diabetes cohort, and they were obese and they had relatively early onset of the disease, but it was mild. And 39%, a substantial part of the NDIS population studied, fell under the mild age-related diabetes, which had typically late onset and relatively low risk of complications. Genetically, the severe insulin-resistant diabetes stands out by neither being associated with the well-established type 2 locus in TCF7L2 gene, nor with a weight risk score for insulin secretion, which are both strongly associated with 3 varieties of the clusters, namely severe insulin deficient diabetes, then mild obesity related diabetes, and mild age related diabetes. And it will be really exciting to explore whether individuals respond differently to medications based on the pathways predominantly disrupted, or whether they have a variable rate of progression and diabetic complications. And for answering that wish, Tanabe and colleagues, this was a study of Japanese population, around 1,520 diabetic persons, and the story was released in 2020. If you see, we need the marker, the diabetic retinopathy, and what were the factors associated with occurrence of DR. So diabetic retinopathy was very common in SAID, that is severe autoimmune diabetes, and contributing factor was a low EGFR. Then diabetic kidney disease was very prominently seen in SIRD, that is severe insulin resistance diabetes, and increasing age and increasing HbA1c contributed to the extra occurrence of this complication. And at the right side you have CAD, which did not reach a statistical significance in terms of p-values, but the numerical numbers were quite visible, and we had obesity and BMI contributing, increasing age, hypertension, dyslipidemia, smoking, so many confounders contributing to the occurrence of CAD, especially in the third group, severe insulin resistance diabetes group. And this is I think the most important slide that I could pick up for this presentation. If we see, if with the permission of the chairperson, can I walk down there, because I can see this. We'll start at the right hand. State, that is their autoimmune diabetes. We expect these patients to be on multiple daily or continuous injections of insulin. They are going to experience hypoglycemia. Then we have cluster 2, which is severe insulin deficient diabetes. They face a plethora of complications like neuropathy, retinopathy, ketoacidosis, and they are frail and may develop pathological fractures. They may initially do well with sulfonylurea or glenide plus the metformin combination, but typically they will require early insulinization, and they are also at the risk of experiencing hypoglycemia. Next we have cluster 5, which is mild age-related diabetes. The elderly population is obviously going to be more frail, susceptible to developing fractures. They have mild cognitive insufficiency, atherosclerosis, atherosclerotic cardiovascular disease, heart failure, atrial fibrillation. They may do well with DPP4 inhibitors and metformin, but we need to be pharmacovigilant. At the top is the right. We have to check their adherence, their activities of daily living. We need to spread our clinical inertia very judiciously with this patient, otherwise they can experience hypoglycemia because they are on multiple other therapies. Next is cluster 4, which is mild obesity related diabetes. Typically, these patients will have more NAFLD. They will respond well to bigonides, SGLT2 inhibitors, DPP4 inhibitors, GLP1 receptor agonists, oral or injectable. And if we do well, if we control their weight, diet and exercise, we can push them to normal glycemia. At the top is cluster 3, which is severe insulin resistant diabetes. We face such patients in our practice very frequently. They can have diabetic ketoacidemia, that is diabetic kidney disease, NAFLD, NASH, ASCVD, heart failure, and atrial fibrillation. They will also do well with metformin, SGLT2 inhibitors, t2d in modest doses, GLP1 receptor agonists, injectable or oral, and they may again require multifactorial therapy because of lipids, because of blood pressure, weight control, and a few of them might require metabolic surgery. These new diabetes subgroups were also explored in the GDS, which is German diabetes study, 1105 patients who were followed up for 5 years. The severe insulin deficient diabetes patients, which amounted to 3% of this population, showed higher prevalence of diabetic sensory motor polyneuropathy and cardiac or autonomic neuropathy at diagnosis in this particular GDS cohort. And this finding suggests that insulin deficiency could play a key role in the pathogenesis of retinopathy and neuropathy, and raise the question as we enter or we are celebrating 100 years of insulin. So this important question is raised whether sick, that is severe insulin deficient diabetes patients would benefit from early intense insulin therapy for the prevention of retinopathy and neuropathy. So can the Scandinavian clusters be replicated in other populations? This was first searched by John Dennis and colleagues, and they assessed the clinical utility of the newly proposed diabetes clusters. They analyzed 2 large RCTs, that was adopt and record, and that randomly assigned patients with newly diagnosed diabetes in adopt or established diabetes in record to metformin, SU, and PCD therapy. The researchers compared the utility of the diabetes clusters with routinely available clinical variables by assigning patients to a cluster and assuming equal risk and frequent response in each cluster, or using specific clinical variables of individual patients to predict risk of diabetes complications and response to treatment. And this important study found similar clusters in adopt and record trials as in the original Scandinavian diabetes cohort. But they found differences in the rates of worsening of glycemia and risk of CKD across the clusters. However, the clusters did not outperform routine clinical variables. These people had 2 arms. One was using routine clinical variables, and second was the actual cluster. So clusters did not outperform clinical variables in explaining the proportion of variation in disease progression. And a greater HbA1c response was observed with t2d in patients with insulin resistant diabetes, that is cluster 3 in this particular study, and with SU in patients who had mild age-related diabetes, that was cluster 5. The authors professed that models that incorporated simple clinical features were better in selecting and predicting therapy than was a cluster approach that assumed that all individuals within the subgroup responded similarly. So the search for ideal classification really is going on. We need to have further studies that are to assess whether clinical variables will outperform a cluster-based approach, especially when we want to analyze incidence of renal or cardiovascular outcomes. And there is already a plethora of ongoing research in this area, which will probably help us offer more personalized medicine in our daily diabetes care practice. Particular, of course, that is a tongue twisting name. This particular author and his colleagues attempted a validation of the subtype and assessed their association with diabetes complications in divorce, leader, and sustained 3 of the recent CVOT. Instead of de novo clustering, they use ND-server reference to assign study participants into clusters based on only 3 parameters: age at diagnosis, HbA1c, and BMI. So they identify the highest risk of CV events in clusters of participants with high HbA1c, low BMI that very closely resembled SIDD, diabetes, but they also could not replicate the increased risk of kidney disease in the cluster B, which was quite closely resembling severe insulin resistance diabetes. The story tells us that still that particular classification is not applicable universally. And that is why our Indians have also contributed a lot. Are the Scandinavian clusters replicable in Indian population? The first study came from Eastern India, and Dr. Paul and colleagues, they applied Scandinavian 5-point classification of diabetes to Indian cohort, a very small group of patients, 64 patients, 41 males, 23 females, and according to this classification, 10.9% of subjects had severe insulin deficient diabetes, 26.6% had insulin resistant diabetes, 31.3% had mild obesity related diabetes, and 4.7% had mild age related. What was missing was stage. There was not a single case falling under severe autoimmune diabetes category. And in fact, 27% of the total 64 patients remained unclassified, and that is why this authors also in the final summary statement, they felt there is a need for modifying or devising a new cluster for Indian population. In fact, average HbA1c of seed and served groups were higher than study average, and in the unclassified group, HbA1c was lower than the average overall average of HbA1c. Urine ACR was higher in the mild obesity related diabetes group. So these are all maybe small but significant observations that should energize us to go for a better India-specific cluster plan. And this is happening because our South Indian phenotype is very different. We have low birth rate, thin fat Indians, lower age at onset of type 2 diabetes, low at any BMI we can develop type 2 diabetes. Our insulin levels will be low, we will be having low or high insulin resistance, rapid decline in beta cell function is a very common thing, low levels of adiponectin, differences in gut microbiota, and then you have the atherogenic dyslipidemia, low HDL, increased triglycerides, small increase in small dense LDL, low vitamin B12 and vitamin D, low muscle mass, increased HSCRP, increased abdominal obesity and visceral fat, NAFLD, so a cluster of features which push us to developing microvascular complications more rapidly and developing diabetes also very early. For the first time in India, identification of clusters of diabetes was done in around 19,000 plus individuals with type 2 diabetes in the INSPIRED study, a very elegant study in a book called by Honorable Dr. V. Mohan Sah's group, and Madam and Bansi was one of the co-authors. And they use 8 clinically relevant variables, which are age at diagnosis, BMI, waist circumference, HbA1c, triglycerides, HDL cholesterol, and fasting and stimulated C-peptide. The C-peptide is always a better parameter to pursue rather than insulin, because there is no hepatic extraction story when we follow C-peptide. And 4 replicable clusters were identified. 2 were similar to the earlier Southwest classification. What was new was IROD, insulin resistant obese diabetes, and third, that was combined insulin resistant and deficient diabetes. Features were the SID, severe insulin deficient diabetes, almost 26.2% of those 19,000 patients fell under this category. Early onset diabetes, relatively low BMI and waist circumference, low HOMA B, HOMA IR, low C-peptide, high HbA1c, increased risk for retinopathy, and overall pretty poor metabolic control. Insulin-resistant diabetes is the next one. I'm sorry, the thumbs are not working. So almost 25% patients fell under that category. They had a lot of insulin resistance and relative deficiency. High BMI and waist circumference, high C-peptide levels, increased risk for decay. And the third, around 12.1% belong to the third group. They had low age at onset, and BMI, waist circumference, HOMA-P and HOMA-I are somewhere intermediate between the first two categories, SID and IROD. High triglycerides, low HDL, highest diastolic blood pressure, and relatively pretty high HbA1c were observed in this group. And the persons that increased risk for both retinopathy and DKD. And lastly, we had MAR, 35.8%, older than patients in other classes, and they have relatively higher HDL-C, so relatively protected from developing various complications, fairly preserved C-peptide levels, milder form of disease. In the novel cluster, combined insulin resistant and deficient diabetes is of particular importance as it is characterized by difficult to control hyperglycemia, and it is fraught with development of so many complications, especially kidney disease and retinopathy. And the coexistence of insulin deficiency and resistance seems to be peculiar to us South Asian Indians, and that is why we are more predisposed to developing various complications. And the clusters identified in the Indian cohort were found applicable to the nationwide representative population-based ICMR India study, which was conducted across 15 Indian states and union territories. In the India population, 34.8% of the total persons were in the MAR, that is mild age-related cluster, 30.3% in the IROD, insulin-resistant obese diabetes cluster, 24.7% in severe insulin deficient diabetes, and 7.6% in the third cluster. So in summary, ladies and gentlemen, further studies would help us to define the usefulness of these clusters of type 2 diabetes, particularly in the Indian scenario, with respect to selection of appropriate therapies, and hopefully in the prevention of complications of type 2 diabetes. Thank you very much for the patience.